Okay, Chapter 12, EMR class, Behavioral Emergencies. EMRs need to give psychological support as well as emergency medical care. You're going to go on a lot of emotional and psychologically challenging calls. But what I do want to recommend to you is we are not trained counselors or trained psychological professionals or anything like that. So what we can do best for the patient is do what's best for the patient. Don't try to counsel them. Don't ask them why something was done. If they tried to hurt themselves, that's none of our business. And all we can do is maybe make things worse. And that has nothing to do with us. So be thoughtful about what psychological support means. Now, we are definitely going to be giving emergency medical care. So 5 factors contributing to behavioral emergencies: medical conditions, physical trauma, psychiatric illnesses, mind-altering substances, and then situational stresses. Once again, we hit that patient assessment, so we're still doing the same stuff. Your scene size up is going to be a very important thing here, because now, as well as any scene, the patient could become a safety concern for us. But definitely here, you have someone that's maybe willing to hurt themselves or has taken some substance that's, not making them act quite right. So we have to be thoughtful of our own safety as well as every other one's safety on there. So when you're assessing a patient who appears to be experiencing a behavioral emergency, you want to make sure that you follow those steps. That's those steps of that patient assessment sequence. We always want to complete a scene size up, a complete scene size up, and we want to make sure that that scene is both safe for both us and safe for the patient as well. So, make sure there's no weapons, or make sure there's no way that someone could hurt themselves or hurt someone else. If they are oriented and responsive, then we want to be able to complete that primary assessment. And what we're going to do is look for that responsiveness, if they're willing to introduce them, or not willing, but are capable of introducing themselves and understanding who they are and where they are and all of that. And then, of course, looking at our A, B's, and C's, so airway, breathing, and then even measuring the pulse. So after that history, we should follow that sample format. Don't neglect to ask about medical problems. Be sure to find out about medical problems. We don't want to overlook parts of this process. So your secondary assessment, that should rule out any obvious injuries and then focus on the signs of medical illnesses. So take a set of vital signs. Tell them, make sure people know what we're doing. So we want to make sure that they know what we're doing, and that I'm going to take your vital signs real quick, and each step of the way, let them know what you're doing. Especially if you're putting your hands on them, like to feel their back or feel their neck or whatever. You make sure that you explain what's going on. So always going to do the same thing, the reassessment, every 15 and every 5, depending on the status of your patient. And if you're unable to complete the assessment, make sure you just document the assessment findings and then the reason not able to. Maybe they wouldn't go along with you, or you're in kind of a critical situation, or whatever the deal was. Now, behavioral emergencies are situations in which persons exhibit abnormal, unacceptable behavior that cannot be tolerated by the patients themselves or by family, friends, or community. That's what our curriculum is defining as that behavioral emergency. 5 main factors contribute to behavioral changes. So medical conditions, things like uncontrolled diabetes and causes low blood glucose. Respiratory conditions also can. And then strokes, head injuries, high fevers, infections, excessively low body temperature. And then, of course, trauma can certainly do that as well. So depression, panic, psychotic behavior. And I didn't mention that psychiatric illnesses was number 3. Number 4, mind-altering substances, so alcohol or obviously a wide variety of chemical substances. Death of a loved one, we're talking about situational stress, so death of a loved one, and then serious injury to a loved one. That can put people, all these things can put people into a bad place. So situational crisis. What that we're talking about is a state of emotional upset or turmoil. So the crisis is caused by a sudden and disruptive event, such as a physical illness or a traumatic injury, even a death of a loved one. Now, these aren't things that we will encounter while we're out in the field as an EMR. These are things that you'll encounter if you're working in an industrial area. These are things you're just going to encounter if you're around people. So we're just talking about people problems. So, most situational crisis, sudden, unexpected, they can't be handled by the person's usual coping mechanisms. Usually only lasts a short time and then can cause some real bad behavior. So what I mean by that is, unacceptable, self-destructive, dangerous, whether that means just the way that they're acting or maybe some choices that they're making or whatever. 4 emotional phases to each situational crisis. So people may not experience every phase during a crisis, but they'll certainly experience one or more. So understanding what these phases are and then why they occur is going to help you be able to treat people a little bit better who are experiencing these emotional crises. So these emotional phases that I mentioned, high anxiety or even emotional shock, denial, anger, remorse, and grief. So high anxiety, what you might see when you see someone, that when you pull up on somebody that is having a lot of anxiety or what they term as emotional shock, flushed face, you'll see rapid breathing, rapid speech, increased activity, loud or screaming voice, general agitation, just really wound up, Emotional shock's often the result of a sudden illness or an accident or a sudden death of a loved one. It's characterized by cool, clammy skin, rapid, weak pulse, maybe vomiting and nausea, and just general inactivity and weakness. It's just that kind of what you think of when someone's found out some really horrible news and it's like, whoosh, everything kind of goes away for a minute. People's blood pressure starts to get cruddy. Because the blood pressure gets cruddy, because they have this sudden vasodilation response, their heart still has to keep up with the cardiac output to keep everything working. So now it's working harder and harder and harder. All of the adrenaline and everything mixed in with the emotions causes some vomiting and nausea, all of that stuff. It's just this one big, almost cascade of stuff going on. So denial, we mentioned denial, refusal to accept the fact that an event has occurred. So your response should be as follows. Allow them to express denial. Don't argue with them. Don't tell them how they're wrong. Try to understand, emotional, psychological trauma that they're experiencing. There's no need to, I'm not saying there's no need to bring the truth into it. That's not what I'm saying. But what I am saying is there's no need to escalate something that doesn't need to be escalated. If it doesn't have a factor in what's going on, if it's not a factor in what's going on and it doesn't matter, then just keep moving forward. Anger. That was one of the steps we talked about. Anger is a normal human response. It's to emotional overload or even frustration. It may follow denial or it may occur instead of denial. So in a crisis, people can vent angry feelings at you or an authority figure. So remember, they're not mad at you. They're just mad at the situation. You happen to be the one standing right in front of them. Or maybe they're mad at you because maybe you did something or maybe you didn't do something. But just remember, we're there to help people. So don't take their anger personally. Just to acknowledge that's a reaction of stress. Just everybody give the benefit of the doubt to people. Remember, what we kind of talked about a couple of times is more than likely you're going to be meeting people while they're having a really, really bad day. Maybe the worst day of their life. Who knows? But we know it's a bad day if they've called 911 or if they've called to help and you're on an industrial site or whatever it is that you're doing. That frustration, sense of helplessness that people can get, that often can build to anger. So, always be professional. Don't react to anger by becoming angry yourself. Just calm, deliberate actions that will help, hopefully, prevent the escalation into violence. And then we go into remorse or grief. So an acceptance of the situation may lead to remorse or grief. They may feel guilty, apologetic about their behavior during an incident or about an incident itself. So sometimes, if you do this enough, you may run into somebody a little bit later that even apologizes about their behavior when they were just really wound up. And we have to have some empathy, put ourselves in their position and understand that, their baby's sick or somebody got hurt or whatever the deal is, and think about how we might act. So crisis management. In an EMR, we're going to follow that patient assessment sequence again, right? All the steps. So scene size up, primary assessment, sample, secondary assessment, reassessment, We're still going to be doing all of these things in these crisis management situations. So we want to make sure that we're talking with people. Introduce yourself, ask them their name, ask what you can do to help. Be honest, warm, caring. The main thing you see, in my opinion, that you see there is empathetic. Don't as you see the guy standing there on the bottom, don't have an uncaring attitude. Be empathetic, understand, try to understand where they're coming from. Unfortunately, in our country, I think we really lack critical thinking skills nowadays. So, and what I mean by that is just kind of looking at something from someone else's point of view. So this person may be just, looking at something a little bit differently than you, see it a little differently, and that's okay. Just try to see it the way that they're seeing it. Not to change your mind, but just so you can kind of understand. Eye contact is good. You've got to kind of know where you are, though, know the room. Some, from what I understand, some cultures do not like eye contact. So you want to make sure that, if you happen to be in a place that doesn't like that, don't do that. Calm, steady voice, honest reassurance. Try not to let negative personal feelings about the person or the person's behavior interfere. And then simple act of kindness can comfort and reassure a patient in a situational crisis. So restatement, this is important throughout really all of your calls when you're trying to figure out what's going on. So restatement, rephrasing a person's own words and thoughts, repeating them back to the person. So, this says it's usually not helpful to say, I know what you mean, or I know how you feel. When we start talking about people dealing with something, we probably don't know what they mean or how they feel or whatever. Just repeat back. So what you're saying is blah, 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 blah. Be honest, give them a little bit of hope, but don't give them false hope. Say, we're going to get you to the right people, or, whatever is the right answer for that moment. So redirection, sometimes a patient, they might be embarrassed about being the center of attention, or may even be concerned about others involved in the situation. So redirection helps focus a patient's attention on immediate situation or crisis. So use redirection in an attempt to alleviate a patient's expressed concerns and draw his or her attention back to the immediate situation. Well, what about grandma? And it's like, well, we want to take care of you. We need to take care of you now. So if the patient's in a public place, move him or her to a quieter and more private location. I always suggest that anyways, because sometimes on EMS calls, you might have something that causes a problem for somebody. They don't want someone to see them acting that way, or maybe you're having to do a physical exam on them or whatever. So anytime you can get a little bit more private, it's always going to be better. And empathy. So ability to empathize involves imagining yourself in another person's situation, sharing that individual's feelings or ideas. And that's something that, fortunately, I don't think is going around. There's a lot of that, but it's going to help you a lot within this job, in my opinion. So one of the most helpful concepts we can use when we start looking at patients in crisis situations. Communication skills. So principles for assessing patients with behavioral problems. So we want to identify ourselves and let them know we're there to help. That's a big thing, is we want to let people know we're there to help. We're there to help them. Inform them what we're doing. Make sure that you have a calm and reassuring voice. Don't be condescending or whatever. Allow patient to tell you what happened. Don't be judgmental. Show them you're listening by using restatement and redirection, what we just talked about. Acknowledge their feelings, and then do an assessment as you are working your way through these things. So in the event that there's some developmental disabilities, CDC data indicates 1 in 6 children has a developmental disability. That's becoming more and more prominent within society and our culture. Those things range from learning disabilities and developmental delays to autism spectrum disorder. And people, like, if you run into some patients with autism, you might see things like, eye contact avoidance. They might avoid eye contact and want to be alone, not look at objects with another person when another person points to them, have trouble expressing their needs using typical words or motions, appear to be unaware when people talk to them but respond to other sounds, have trouble adapting when their routine changes. So also they don't like to be held or touched very much either. So a lot of things that we've got to keep in mind. And if you have, always take a partner with that. So maybe you're running a call with a child with autism, but mom or dad's there, or caregivers there. Make sure we kind of phone a friend and ask them about that, and ask them what's the best way to do this, because they're probably going to know that. Crowd control. Performing simple crowd control can help reduce a patient's anxiety when there are just way too many people around. And way too many means more than what they want. So any emergency personnel who are not needed right away should leave the room until the patient is calm. What happens is you get 6 people in there. What happens is you get 2 or 3, EMS workers, you get 4 firefighters, 2 cops, and a family member, and all these things. The next thing you know, someone is getting very anxious and overwhelmed because all of this attention is on them, and somebody in that room has a stupid look on their face as well, and they look, they just got their dinner interrupted, or somebody had to leave the recliner, or whatever the deal is, and then it's making things worse for them. So if they don't need to be there, just ask them to wait out in the living room or whatever, and then you can tell them, hey, sorry about that. I just want to, kind of give them some privacy. So during your initial size up of the scene, determine whether there is a crowd that might become hostile. It can certainly happen. It's not nowadays. You can certainly have a hostile crowd. So it's better to ask for help with an unruly crowd early than to wait until it's truly unsafe for you and your patient. So stay ahead of the game. Domestic violence. So unfortunately, we do quite a few calls with domestic violence. It's a common occurrence in today's society. So it's different forms, has some different forms. So elder abuse, child abuse, spouse or domestic partner abuse. We need to be able to recognize signs and symptoms of abuse and understand 3 phases in the cycle of abuse. So when responding to domestic violence, you need to maintain safety for all rescuers as well as the patient. So we want to be thoughtful about maybe separating people, or however that thing happened, just getting someone right off the scene and into the back of the truck, or whatever works. Conduct an effective assessment, provide treatment, and then you need to understand your requirements for reporting abuse in your state. You need to figure out your agency that you work for, whether that's a company or your local city or county fire department. All of that will be in place with them. So just make sure that you find out what the deal is. Signs and symptoms include physical injuries. So physical injuries, there's emotional injuries, lots and lots of things. So broken bones, cuts, head injuries, bruises, burns, scars, internal injuries, lots of stuff. Within those emotional injuries, now we're talking about depression, suicide attempt, abuse of alcohol or drugs, feelings of anxiety, distress, hopelessness. The abusers may be paranoid or overly sensitive, obsessive, or threatening. They often use alcohol or drugs and have access to weapons. I don't know how true that statement completely is, that our curriculum tells us, but everything can be used as a weapon, so that's not a big deal. Just a butter knife is very dangerous in the hands of the wrong person. But what you will see is what the point was about the abusers, paranoid, overly sensitive, all of that. They can certainly be that when you start putting some attention on someone that they've abused. So all of a sudden, they don't want them talking. They don't want them to leave the room. They want them to be there with them, all of that, because they know some information may be coming out. So just be aware of that. If you do suspect abuse, it's your responsibility to maintain safety for yourself and for your patient. So keep everybody separate. That's going to be the best thing that you can do. And then as you question your patient, we want to be concerned for them. And we also want to try to keep from judging them, because it might be easy to judge someone when this is the 10th time you've been over there for the same thing. We don't know what people are going through. So if they do refuse transport, you may need to provide some information about maybe a domestic abuse shelter or whatever. It all depends upon where you're at. So in some cases, the presence of law enforcement personnel will be helpful. Anytime you go on a violent scene, in my opinion, you should have law enforcement personnel there, and then they can get involved with whatever this looks like. So make sure you learn the requirements for your local city, state, whatever. Cycles of abuse, I mentioned that a second ago. So tension phase, so the abuser becomes angry, often blames the victim. The victim may try to placate the abuser or minimize or deny abuse. And then tension phase is usually the longest part of the abuse cycle. Then you have the explosive phase, so they become enraged and loses control, as well as the ability to think clearly. Now, most injuries to the victim occur during this stage. Then you have the makeup phase. So abuser makes promises, which of course are seldom kept. Person keeps abused person in relationship with the abuser. That's what this does. This phase does. It helps keep them connected still. So you, knowing those kind of phases, understand you may enter in any one of these phases. And as you know, as what we just said about the explosive phase, by that term, it can become explosive. So remember, we use the word enraged, loses control. So you may end up walking in on something that's becoming that phase. So just be thoughtful about it. Violent patients immediately attempt to establish verbal and eye contact with the patient. That's what we should do. Begins the process of establishing rapport. So check with the family members and friends about the patient's past history of violence. We want to look for any signs of potential of violence that you see there. History of violence, yelling or verbal threatening, loud, obscene, bizarre speech, abuse of drugs or alcohol. And we never want to force a potentially violent patient in a corner. That's going to be a real problem because, as when we talk about dogs and cats, well, imagine a really enraged person, how they feel when you do that. So we don't want that. That's a really good way to get hurt. But you do not want to allow yourself to be cut off from a route of retreat either. So whatever that means, you always want to have a clear path. So do not get caught behind something to where you are unable to get to the door, having the person between you and the door. That's not something that you want. Have only one person talk with the patient. So communicator should be rescuer with whom the patient seems to have the best initial rapport with. And then we also need to anticipate the need to summon law enforcement if all other means of approach and intervention fail. Now, as I said, the way that personally, I've been on off into these scenes, I pretty much don't want to go on these without PD there or, county or whoever. So if you have them on scene with you, then you've already anticipated your needs and, your things are moving in a much better direction. Plus, it's easier to keep people separated and to find out true and valid information versus someone being intimidated by someone standing across the room from them or whatever. Now, violence against us, violence against EMRs and 911 workers. So several factors increase the risk of violence in the workplace. So working alone or in small numbers when there's only a couple of you, working late at night or early in the morning, high crime areas, working in community settings. So these are all ways that, things that there could be a risk of violence for us. So it's, you want to be thoughtful and kind of really pay attention, have some good management skills, scene management skills, and be aware. Situational awareness is the word I was trying to find. You want to definitely be situationally aware while you're out on these calls. So be alert when you respond to a call that has an increased chance for violence. So what is that? Well, crime scenes, incidents involving gangs, large gathering of hostile or potentially hostile people, domestic disputes. Things can certainly get out of hand, like in the middle of summer and you go out to the lake, or you go to the city park, or you go to a family reunion, and all of these kinds of things, because people just feed off their, the energy that's there. So now, ways to minimize your risk of injury. So take steps to keep yourself and other rescuers safe at these scenes. Always keep an escape route. Always keep an escape route. We've mentioned that, but it's a big, big point. Prevention is going to be the best way to avoid violence. So as you arrive at scene, we definitely want to pick up any signs that you might be approaching a violent situation. So, keep your eyes and ears open and listen and situationally aware through it. Always make sure you have a good escape route in mind. Ability to use good interpersonal communications. Interpersonal communications will help prevent many situations from becoming violent. You start to pay attention to people's body movements and their feet positioning and their hands and all of that. You can kind of see when somebody's kind of working themselves up to do something stupid. So, armed patients. Not your role to handle an armed patient unless you're maybe a law enforcement officer. Many times we have law enforcement officers come through EMR classes, and that's who's going to handle that, hopefully. So be alert for potentially threatening situations. Summon assistance if you think someone is armed. Stay in your vehicle if you must wait for a law enforcement officer. In these kind of situations, you want to be staged. So as I've told you before, not just right down the street. You want to be away where people can't see you and involve you in this thing. Now, medical and legal considerations. So you need to understand the laws of your state as well as your city or county or however these laws are written that relate to dealing with emotionally disturbed patients. So if an emotionally disturbed patient agrees to be treated, there's nothing, typically there's no legal issues. If a patient who appears to be disturbed refuses, it may be necessary to provide care against that patient's will. You're going to want to always refer to your local protocols of what that looks like, or involve your local law enforcement. They may need to be EOD or emergency order of detention or something. So you must have a reasonable belief that they'll harm themselves or others before that can happen. So before you start involving other people, make sure that you truly believe that this could be a real problem. Now, as an EMR, you usually will not be responsible for transporting the patient, but you should know what the laws in your state permit you to do. So typically, like I've said, EMRs are not on necessarily the ambulance. Usually it's more along the lines of a fire or rescue unit. But if you are required to restrain a patient, and consider these factors. So their size and the strength, so you want to make sure you've got more hands on them than you need. Their gender, where hands go and what things happen, and just be thoughtful about everything, type of abnormal behavior, their mental state, and then how you're going to do it, the method of restraint. Reasonable force to defend yourself and against an attacker. So, if you have an emotionally disturbed patient that's starting to attack you, you have the right to defend yourself. So to prevent problems, if you must restrain a patient, you want to seek assistance from law enforcement or from your medical director. Don't just typically go and do this on your own. Now, sometimes you don't have opportunity. Sometimes things get out of hand and you don't even know it, and you end up just restraining them. Then you can involve your medical director or PD or whoever. But you need to get to make the situation safe before you worry about all that other stuff, because your safety is always first. So then document the conditions in cases where you must restrain or subdue a patient. So you want to talk about why you restrained them. You also want to talk about how you restrained them, and then that they have pulses before and after and all that kind of stuff. So there can't be a lawsuit afterwards. So many patients, we're talking about attempted suicide. Many patients who fail at the first attempt probably going to try to commit suicide again. Each year, thousands of people, from teenagers to elderly persons, are attempting suicide. So many patients who fail, as we mentioned, they're probably going to try again. So most people who attempt suicide have a serious psychiatric illness. And what we're talking about is, depression, alcohol, substance abuse. They have some type of, serious thing going on in their life. At that moment, they may or may not be under the influence of drugs or alcohol. But usually the underlying problem is usually treatable, and with the proper treatment, no longer be suicidal. So review your risk factors, make it more likely that someone will consider or attempt suicide, and it's on table 12.1 in your curriculum. But protect yourself and your patient from further harm. Make sure you get a complete history of the incident, and then determine whether the patient still has a weapon or drugs on them. But management, support A, B's, and C's, dress any open wounds, treat the patient for spinal injuries in the event there is one. You shouldn't have to say that on there. Do not judge patient. Hopefully we're not. Hopefully, as we said, we don't realize, what people are going through. Maybe there's a guy that is supporting his family and he gets fired from his job and he can't get a new job, and all these things. It's just things that are overwhelming, and it's pretty easy to get overwhelmed anymore. PTSD, post-traumatic stress disorder. So I think this probably goes on with a lot of things going on throughout the world, whether you've come back from combat or in a bad car crash, or you've been on the streets for a while, or, as in the 911 world, or you are a victim of abuse or whatever. PTSD is a big thing. So mental health or behavioral condition, and the thing is, it's triggered by experiencing or witnessing a terrifying event. So what happens with this, unless things, are able to get kind of sorted out, they typically get worse with time, and that anxiety often interferes with the normal day-to-day activities. So Symptoms can include intrusive memories of the traumatic event, so kind of replaying things, avoidance of the places and activities and all of that reminds them of that, negative feelings, emotional reactions, lots and lots of things. So, protect your patient from harm, speak with the patient in a positive, supportive way, make sure that we're getting them wherever they need to go. Now, sexual assault, psychological aspects of treatment are going to be important with these patients. So, with all these patients, they can be anyone, old, young, men, women, of course, children, lots and lots of, it's open to everybody. So you may have to delay all but most essential treatment to respond to the same sex as the patient arrives in the event you need to do a full physical or something. That's not really our part to get really deeply involved in this stuff, but our first priority is going to be the medical well-being of them. So we want to make sure, as we've said, we want to treat those injuries. So our A, B's, and C's, and treat any open bleeding and any wounds and all of that type of stuff. If you do have the opportunity to have a same-sex partner that can take care of that person, the female was the victim and you have a female partner, there's going to be you don't want to be the guy. I've had to do that before. You don't want to be the guy where, their people are just a little bit shook up and don't necessarily trust really many people right there. So obviously this is a crime. We don't want to remove clothing. Try to convince them not to bathe or use the toilet because of evidence reasons. All of this stuff is evidence reasons. So not to remove clothing and not to go to the bathroom. Try to keep the scene as undisturbed as possible. Avoid aggressively questioning the patient about the incident. Make sure, once again, we're using empathy when we're treating these people. In the event that we need to do some things, we want to make sure that we are providing them with lots of privacy, whether that's sheets or blankets or whatever. We don't want to leave these patients alone either. And then death and dying. So obviously this is going to happen to us. We're going to encounter some death and dying when we're talking about working in 911 services. So natural, accidental, intentional, all of these ways. So we want to do whatever we can to meet the medical needs, as you see. Once again, that's our whole assessment and our ABCs and whatever it is that needs to be done. We want to be able to do that. So your attempts to save or give comfort to that patient, that can help everyone deal emotionally with the patient's death. So most people are afraid of dying. So work through your personal feelings about death so you can confront it in the field. You can look at it this one of two ways. It's a burden or it's a blessing. You get to be the one to spend the last few moments with someone who was really important to somebody else that another person would give anything to get to spend those last few moments with somebody, or vice versa. You're one of the lucky people also that might catch a baby that gets to be there when a new life is given. So it's all about perspective and how you look at these things. So it's all about whether I have to or whether I get to. That's what 911 is all about, whether I have to or whether I get to. You're making the choice, or someone might be making it for you, but to go through EMR and to become a servant in our community and wherever that community is or your business or whatever. And, you get to have the opportunity to get to help people. And that's not something a lot of people have that are willing to step into. So it's kind of a big deal. So death and dying, consider the psychological needs of the patient. Don't be afraid to touch. Make positive statements, but don't give false hope. Say, everything's going to be okay. And, when Mima or Papa or whoever is, it's pretty clear that they're not doing very good. Provide comfort in any way you can. People just want to be comforted in these moments. Know that somebody recognizes them, somebody sees them, somebody knows who they are and what they've done and all of that. So like I said, you get to be somebody. Emergency care is stressful, so work-related stress. Emergency care is stressful for EMRs. If you didn't know that, it is. If you let this build up without releasing it in healthy ways, meaning maybe that means talking with a spouse or talking with people that you work with, or obviously going to the gym and really getting all of that stress and energy out. The problem is without some way of dealing with all of this, it can have negative effects on you and your performance. Not only your performance at work, but your performance at home as well. So your performance as a mom or a dad or a husband or a wife or whatever. Some of the things that you might see with that extreme stress is depression is not uncommon, inability to sleep, or even people that are sleeping, too long because they just don't want to get out of bed, weight changes, increased alcohol consumption or drug abuse, inability to get along with people, lack of interest in food or sex. So there's lots of things that are out there. CISD is something that is I don't think we do it very well because in the 20-something years that I've done this, I haven't been a part of this very much in an organized effort. So it's something that we definitely need to work on. Critical incident stress debriefing, so peer support. To help prevent excess stress and relieve stress that we get by these critical incidences. Psychologists have developed a critical incident stress debriefing, so a CISD process. So that brings rescuers and a trained person together, talk about the rescuer's feelings. So, it wasn't that long ago that the whole thing was, kind of back in the day, was suck it up, buttercup. That was pretty much the mantra of all 911. And now there's a lot of, circles and we're talking about things. But if you've been around very long, you've got to do something with this information. So whatever, you've got to do something or you bottle it up and it will become a problem. It will catch up with you. So these things, these CISDs, they may help rescuers understand kind of how to recognize this stress as well as what to start doing with it. Peer support is a process involving properly trained members of your department. It kind of helps you out, provides confidential support, to another member who's experiencing personal or emotional work-related problems. All these kinds of things really affect how we do our job and how we are able to take care of each other. So a lot of times this kind of CISD thing just happens maybe at a recliner back in the station. You just start talking about some things and that really sucked and, blah, 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 blah. And you keep going on and you just get some of that stuff out because until it gets out, it's just all stuck in there. So the summary, I don't want to read back through all this stuff. So it's in your book. You can look at the summary. We've kind of harped on all this stuff. So that's it. That is, what did we do? Just do chapter 12. Chapter 12. So I'll see you for chapter 13.